Welcome to this episode of All Synapses. I'm Diana Dahlmeyer, an internist, epidemiologist, and researcher in geriatric medicine. I'm also curious and passionate about communication. This time, I had the pleasure of talking with Dr. Hanna-Maria Roitto from the University Hospital of Helsinki in Finland about dementia. We had a very pleasant conversation about this sensitive topic. I invite you to listen to it to learn about the signs or symptoms that should prompt you to seek medical advice, why a timely diagnosis of dementia is important, what to expect when visiting a memory clinic, and the important role of families and society in addressing it. Enjoy it. So, hello everyone to our next conversation here at All Synapses. Today is a very special day because I have a very special guest. And we're going to be talking today to Dr. Hanna-Maria Roitto. She's coming from Finland. She works as a geriatrician at the Helsinki University Hospital and is also a medical advisor at the Finnish Institute for Health and Welfare. Hanna-Maria has a specialty in geriatric medicine and general medicine with special competencies on memory disorders, and also a PhD at the University of Helsinki. She also has received this year the award as the Geriatrician of the Year in Finland, given by the Finnish Geriatric Society. She's very active in the special interest group of the European Geriatric Medicine Society, and we know each other now for about 7 years. Yes, because we took together the course at EAMA, at the European Academy of Medicine of Aging. So for me, it's a real pleasure to have you here, Hannah.
Thank you so much for having me.
Yes, I'm really looking forward to this conversation, because I think it's a very sensitive topic, and sometimes, unfortunately, we don't talk to the community the way we should. So what do you think about the way this topic has been approached in the media? Just to start with this.
In general, about dementia, neurodegenerative diseases, I've been actually quite happy in a way that I like the fact that dementia prevention is very much on the media. So it's nice that these things are brought up to the general public. But as you said, I am a little bit concerned that the way they are brought up, it's more by fear. Like, if you don't want to get dementia, what do you need to do? Do this and this and that, so you will not have dementia when you get old. So I think the connotations are actually quite negative, and they can also bring a wrong image to the general reader. From my perspective, working with people who have dementia and who come forward to have these memory diagnostics, we should talk more about people who have dementia and how to live well with dementia. I mean, of course, dementia prevention is important, but I think we just show like one side of the coin, not the other. So hopefully we can, with our conversation today, bring light to the other side as well.
Yes, this is why I'm really looking forward to. I'm actually preparing this conversation, reading some of the papers that you work, maybe just to give a sense to our listeners, like Alzheimer's disease is actually like only 5%. Only 5%, no? 1 in 20 above those 65 to 74. And when we talk about dementia, it's also, and I know that people get very, as an honest, it's a very difficult condition. And as soon as you forget something, you start to get in panic.
Yeah.
No, because you think, I'm developing this. And I think it's maybe important just to explain what's happening in our brain as we age. So how do you see this from this perspective?
It's true. This is also a thing that has two sides. Not to create panic. That's not necessary. It's important to know that there are changes in our cognition as we age. So it takes us longer time to learn things. When we are tired, we might forget things more easily, or things affect us more because the cognitive reserve is not as good as it used to be. So in a way, I mean, in that way, you are right. Like it's normal to forget things sometimes. We all do, younger adults and older adults, for different reasons. So it's not always dementia. But then I suppose this comes from my perspective, because I do see people who have dementia and they do not seek treatment because they think forgetting things is a part of normal aging, or they think that dementia is a part of normal aging, which it is not. So, I mean, you shouldn't be worried about everything you forget, but then if there are changes, then I think that's when you should actually seek medical help or look for memory diagnostics.
So I like the point that you point out this, because it actually reflects the fact that we need to do a lot of work in educating about the topic. No?
Yes, for sure.
Like, it's true that in the past year, let's say 50, 60 years ago, nobody talked about dementia the way we're doing now. And perhaps they were thinking this is normal to the aging process.
Yes.
And I guess when you talk to your patient and ask about their parents, so yeah. What did they say? What do they say?
I mean, I hear this every day at the clinic, that isn't it normal? Like, I'm already 80. Isn't it normal that my mom forgets? Or isn't it, or the patients themselves say, you know, if I'm over 80, I mean, it's normal that I don't remember things. So then it is really a question about educating not just our patients and their family members, but I also think the general people working in healthcare and social care, because like you said, 10, 20 years ago, this was maybe considered normal, but now we know that it's not. So these kind of conversations like we're having now are needed to disseminate the fact that there is not an age when it's normal to start forgetting things.
Thank you. Thank you for pointing this out so clearly. So when you talk to family and caregivers and patients, or to our listeners, what would you say will be like the hints that they need to pay attention? Now, if you're having your father, your mother, when are the time, or self the patient, when is the time that you think maybe it's a good time to look for help now or visit the doctor?
That's a very, very good question. It's a little bit also a hard question, because our brains are different and the diseases are different. So the symptoms that appear can also be very different. But if we think about, well, in general, I think the important word would be change.
Okay.
If you see that your parent changes in a way, that she used to be something, she used to do like shopping, she used to do cooking, and now you see that she's not doing that anymore. So there's a change in the things that they are able to do. So then that's a good thing to ask, like, why? Why has this changed? I think the most important word would be change from what was previously to what is now. If we think about specific dementia disorders, then Alzheimer's, that's the most common one. The most typical first symptoms are that you forget things that have already been talked about, or you forget things that have happened. So, for example, if you've called your mother and you've told her what you've done, and then later on in the same conversation, she asks, oh, well, what did you do yesterday? So that would be a sign that the episodic memory or the short-term memory, it's not working like it's supposed to be. So this could be a symptom of an Alzheimer's disease, for example. other symptoms that people probably not recognize as part of dementia or memory disorders could be loss of appetite.
Okay.
Problems in walking, or falls, or problems in balance. And then hallucinations and delusions are something that can also scare the people themselves or the family members. But these can be signs of memory disorders or dementia. So, and this would also, I come back to my word of choice, change. This would be a change from a previous condition. It's something that appears that was not there before.
Yeah, so as you mentioned all of these factors, I think it's important, or it's clear for us how complex the disease can be.
Yeah.
You know? And not for everyone is going to be the same symptoms. But I like that you point out the fact of change. The change in any case that is the person is not being the same as it was supposed to be.
Yeah.
And I think we talk, but we talk in medicine about apathy, no? And you actually see the patient is like retracted and it's not more communicating, interacting. Something is going on.
Yeah, if I can tell you one example.
Yes.
I had a couple who came to the memory clinic, and the husband had always been very generous and always had remembered the wife's birthday and the wedding day and all these kind of things. And then suddenly he didn't bring a gift on the wedding day, or he didn't bring a card or a gift on his wife's birthday. So then the wife had thought, like, what's happening, that he doesn't love me anymore, or and then, well, things resolved, and then what we found out, that then it was early Alzheimer's disease, and it was apathy, and it was memory loss. So then actually for the wife, this was a huge relief to understand why her husband had changed, what was behind the changed behavior, that it was not that he didn't love her anymore, but it was just due to these symptoms.
Thank you for sharing this example, because I think this is a really very good one, and how sometimes we confuse what we see.
Yeah.
And putting all the puzzles together, what you do in the memory clinic, it helps to elucidate what's going on. I also like the fact that you mentioned that dementia also affect other functions in our body, like the motoric function, the association with falls, and also the fact that we can get some other symptoms with hallucinations and delusions. So it's just about, and I guess the message here is the ones who can better say something is going wrong are the caregivers, the relatives, the family.
Yeah. Yes, that's right. It's often the family who notice the changes, but that's also very case specific. Each person is different. Sometimes people themselves, they notice that they feel more insecure, maybe, because if you don't remember what you don't remember, you can't remember that you've forgotten. So it might be hard for the person themselves to understand the symptoms, but I would say that they do realize that something is going on. But it could be like insecurity, like you said, they maybe also become apathetic. It's harder for them to leave the house, because it's easier and safer to stay in an environment that you
feel comfortable.
Going to, exactly. So going to a new environment where there's lots of people, that you might feel a little bit lost. So all that could be.
And also irritability in this context could be also a symptom, no? Maybe someone is refusing to go to the family reunion or becoming aggressive. It's a way to send the message, exactly, I feel something is not good.
Yeah.
And this is a very important point, actually.
We all see it from our own perspective.
Yes.
The person who has fallen ill sees the situation very differently than the family members. And it's important to, I liked what you said earlier about bringing the puzzle pieces together. That's exactly what we do at the memory clinic. That it's so important to hear all the different sides of the story, because then you get the whole picture, and then you understand what's going on, and then you can also explain to the patient and to the family member what is going on and why they see these things differently. And I from my experience, this already helps, knowing what's going on, because then you know how to handle these situations at home, for example.
Yeah, that's actually a quite important point. So when we talk about diagnosis, I remember preparing this talk that you like it to point out differences in the term that are used outside related to diagnosis. So maybe you want to comment on this, because I think that's quite important. You mean the early and the timely diagnosis?
Okay. Yeah. Yeah, there's actually a lot going on at the moment in the field of Alzheimer's and in the field of dementia diagnostics. We're getting new biomarkers, new ways to diagnose Alzheimer's disease and other dementias. So when we talk about diagnosis and when we talk about disorders that are progressive, like Alzheimer's disease is, it would be good to make the diagnosis early. And early meaning that when we make it at the beginning, we can help the patient and the family members understand what's going on. So this causes then less suffering when it's understood what the symptoms are and how they can be treated. Also, the treatments that we have, they're more effective if they're started early. So then for the treatment and rehabilitation and for like the general just messaging, it would be good to have it early. But then the question is that how do people understand early? So what I like to use more is to talk about timely diagnosis, because some people, this is maybe in the science community more, but people use early as a stage when there are no symptoms yet. There are just changes in the pathology in the brain. And we actually don't always know if these changes lead to symptoms.
Yeah.
So if we get to a diagnosis too early, it could cause unnecessary suffering, because even though we have that pathology, it doesn't always develop into Alzheimer's disease. We have older adults who have this pathology, but they never develop symptoms. So this is the reason why I like to talk about timely diagnosis. And with timely, I mean when there are symptoms, when something is changing, then you should go and seek medical help and seek diagnostics. But then it's also important not to wait too late. I mean, if you notice symptoms, if you notice changes, don't hesitate. Always you can talk to your doctor. And if your doctor says that this is nothing to worry, then also the person who was worried knows that, okay, so then it's not Alzheimer's. This could be, just because I'm tired or I have the wrong medications, or there can be many different reasons.
Yeah, that's good that you point out this, because before putting the diagnosis of Alzheimer, the physicians, we all work in different other conditions just to rule out and be sure that no other issues are going on. And I like the fact that you differentiate between the early and the timely. And I think here the main message for us as physicians, so one of the main, how would you call this, principles that we have is not to harm.
Yeah.
Yes. And we don't really, I agree what you say. It's not all right to put this kind of stress, create anxiety, if at this point we cannot say for sure in which direction, who is going to develop.
Yes.
And I think there's a lot of work going on with this. So I agree completely with you that the principle of no harm should be on the top of our profession.
Totally agree with this.
It's very nice. And I'm just curious because I like this exchange too, because we come all from different countries.
Mm-hmm.
And one of the experience, or one of the main gain that I obtained from EAMA was to realize how different the health systems are in the European countries. And so maybe if you can explain to our listeners what it is a memory clinic. So what are the components of a memory clinic and how long this has been in Finland? Mm-hmm. Just explain a little bit, because I think that is something that is not everywhere and it's quite interesting to understand.
That's a very good question. And it's actually very same things that I learned from the EAMA course. And before I go to the Finnish experience, maybe I would like to tell the listeners how differently memory diagnostics are done in different countries, that they're done by different specialists. That in some countries, it's neurologists. In some countries, it's geriatricians. In some countries, like the UK, it's psychiatry. Okay. So, I mean, in different countries, it can be different specialists who are doing these diagnostics. In Finland, it's neurologists for the younger patients, so people who are in their working life, under 65. And then when you're retired, if it's memory diagnostics in this age group, then in Finland, it's a geriatric outpatient clinic or a geriatric memory clinic. And why this is done, like you pointed out, it's not just about the memory, but we often need a comprehensive assessment on lots of different issues. So it's thought that geriatricians are best experts in this field. But before the people come to the memory clinic, they've normally already been to their GP, their own doctor, who has done like basic checkups, basic laboratory to rule out some conditions that could cause these kind of symptoms. They have checked the medication list. So, I mean, there can be some kind of vitamin deficiencies, or there can be some medications that affect the memory. Then at their own doctor, they should also check these kind of basic memory tests to see a little bit like how do the people perform, to give us an idea what kind of investigations we need to go into more like deeper detail. And then what we always want is when they are referred to us, that in the referral, the doctors, they should write the name of the family member and a phone number of the family member who's going to come along. Because this is, when we talk about dementia or memory disorders, these are things that often affect the whole family. So it's very, very important that the family members are aware so that they can bring their insight and also that we can guide them. So we have big rooms, we have big tables, and we have chairs for the patient themselves, but then a spouse or their children or, you know, whoever is the closest family member. We've sometimes had the whole family there, and it's nice. In that, it is a very good thing.
Yes.
So, I mean, the patient feels safe, and then we all are able to have a conversation and help each other in this situation. So this is like all done before, and then they come to see us. Our memory clinic, I think it's, maybe this tells the listener that it's not really such an old field, because I'm thinking that our memory clinic is maybe 20 years old. So this is all quite new. But we've grown in the last 20 years from like one physician to now we're 7.
Okay.
So it's a big clinic. We're maybe about 30 people working there full time. So we have doctors, nurses, memory care coordinators, physiotherapists, speech therapist, occupational therapist. I think that's pretty much our interprofessional team. And the people, when they come to see us, they see a nurse, then they see the doctor, and these kind of memory scales and tests are done. And then we also do always either a head scan, a CT scan, or a magnetic resonance scan, which is a little bit more detailed. So the head is also a scan to see what kind of changes there are, because the symptoms that appear, they come from the changes that have happened in different parts of the brain. And then, like you said, I come back to this puzzle.
Yes.
Then we bring together all the pieces, the memory tests, the symptoms, the brain imaging, the lab work, the experiences from the patient and the family members. And that really then gives us the whole picture that what is going on, which is the most important question, because then when we know what's going on, we know how to treat it, what kind of rehabilitation is needed, what kind of medications we should start or stop. And this all takes the doctor's consultation. It's 1.5 hours.
Just the doctor?
Just the doctor. And then normally we have nurses visit on one day and then the doctors on another day.
Because it's very
it's a long time. So it really, it is quite consuming for everyone. But I think it's really important to bring all the pieces together at the same time, because we know from studies that have been done that this is the way that you can also get the best results. So quite a long story, but like you said, it's complex, but it's very rewarding, I think, for everyone.
So your memory clinic is based in Helsinki?
In Helsinki, yes.
And is this the only memory clinic, or there are different memory clinics?
That's the only geriatric memory clinic in the Helsinki area. Then we have the neurology clinic for the younger adults.
So we're talking about how many people are living in Helsinki, just to get a sense?
500,000.
500,000. Okay. I would like to point out here for our listener the importance of this interdisciplinary team. No?
Yes.
Because you need to have not only the physician on board.
Yeah.
Physician is, I would say, the main component and usually the leader of the team.
Yes.
But you also work together with other specialists, no? Physiotherapy, logopedy,
yes.
Social worker to address some social issues, ergotherapy. So it's a very comprehensive evaluation and work together.
Exactly. And depending on the evaluation that's done initially by the nurse and the doctor, then, for example, if we see that there's a need for the physiotherapist, then we send them to the physiotherapist, or if we see that there's a need for occupational therapist. So it's all depending on each patient. It's not everything for everyone, but depending on the specific needs, then we organize the rehabilitation and the treatments that are needed.
And I want to say, because you mentioned you started with one physician, now you're 7 physicians, and sometimes we go to the wrong conclusion that people could say, oh, now we're having more dementia. No, it's actually, I think it's not this. Maybe we need to point out, it's also because we're becoming better in the understanding of the disease too. Yes. And the need of all these comprehensive teams to work on this. So it's not to get the wrong message, that people think, oh, now we're getting, and also because we know that aging is not normal. It's not normal on the process of aging to have difficulties with memory and other.
Yeah, I would say you're exactly right. We know, in a way, if I can use the term prevention here, that in general, prevention is better than treatment. So, and I'm not talking about preventing memory disorders, but I'm talking when somebody already has Alzheimer's disease, we can still do prevention. We can prevent falls, we can prevent problems at home, we can prevent a lot of things. So, I mean, it's never too late. And we know that it's better to tackle these issues at the root in the beginning before we do have the problems, because it's, of course, it's worse for the patient, and then it's also more expensive for the system. So in this way, I think it's important that we have a bigger clinic at the moment so we can treat more effectively. And then, like you said, it's not that dementia would be getting more common. Actually, there are numbers that saying that the incidence is coming down. But what is happening in Finland, I don't know, probably in Germany and other European countries as well, but that the population is getting older. So we have more people who are older. And in that meaning, when age is one of the risk factors of dementia. So if we have more older adults, we do have more cases of dementia. But it's not that there would be more per se, but it's just due to the population aging. So there are different reasons why the clinic has evolved and changed during the years. But I think the most important being this, that we have more data now that something can be done, it can be treated, and it should be done at this stage. So it's very much, all the work is driven by the new research that has been done in the last 10 to 15 years.
Very nice that you mentioned, that you summarize like this. I think it's also important because you talk about prevention, or maybe we can give some hints about how important is, like building a routine in the daily basis, paying attention to the sleep for the patients. So I think this is the kind of information, nutrition, of course. So these are like we call the basics, no? And sometimes I think we should emphasize this, because sometimes we think, and we see patients who say, you're not giving me medication, you're not treating me. We all have had this situation, no? Are you not giving me the pill? You're not treating me. And that's actually not the case.
No.
I mean, yeah, it's true. And sometimes the basics are not considered as a treatment.
Yeah.
But the basics as important as sometimes the medical treatment.
Yes. I think it's changing in a way that hopefully the general understanding of it, but we do prescribe exercise.
I love it. You prescribe it.
We prescribe it. And we do prescribe social interaction.
Prescribe social interaction.
Yes. Because...
And when you say you prescribe, what that means? Is it you have you send them to a social work? Okay.
Yeah. Yeah. At the end of each consultation, we write down all the plans, and it's not just that it's the doctor. Okay, I need to step back a little bit.
No, it's okay. It's complex.
It's complex. I mean, I do prescribe it from like a doctor's point of view, but I don't like the fact that a doctor would be ordering anyone to do something, because that doesn't really work.
I love that you point out this.
I'm not going to be there at home. What I actually do is we work out the plan together. So if you will, we prescribe together, because it depends on the person's own needs and motivation. So I have 2 questions that I ask my patients at each visit. And one is, what things are important to you? What things bring you joy? What do you like doing? And another question is, what fears do you have? So then, based on this information, I can, from my medical experience, then say, okay, so your biggest fear is that you have to go to the hospital, for example. So for that not to happen, this is what we should do.
I love it. Very nice.
And then, or if they say that, like, I really enjoy going to the concert with my friends, or so then, okay, for you to be able to continue to do that, this is what we should do. So we can we can do the plan together and base it individually, because then I feel from my perspective that the person is going to be motivated to do that because it really serves her. Nobody wants to do exercise just to be able to get up, like, or just to be able to go to the bathroom. For maybe, I don't think that would be enough. It needs to be meaningful. So that's my step back from prescribing.
So I love this point, and I think this encourage a lot of us as physicians and as patients to understand that we need to have a sincere conversation.
Yeah. Yes.
No?
Yes.
So we need, and I think it's important patients need to be get the space to talk about their fears too.
Yes.
Because sometimes we don't listen to them.
Yeah, I mean, this is just assuming, I don't know, but it could be that sometimes people maybe fear these, doctors maybe fear making these questions, but I would encourage, I mean, if your doctor doesn't ask you these questions, you can bring these up yourself. Sometimes I feel that older adults are too humble. They don't demand things for themselves, or they themselves are a little bit ageist. They are saying that, oh, you shouldn't bother with me, or so. I mean, I want to empower the older adults to talk and to demand to have a conversation with their doctor and to say, what do I need to do if I want to stay in this shape and I want to do these things? What would you advise me?
I'm going to cite one of the phrases that you have in one of your papers that you put it out. We will always be younger than our patients.
Yeah. Yeah.
And I think this is also important because it could be also for the older adults, like they feel ashamed or they don't feel comfortable talking about their vulnerabilities to a young person.
Yeah.
And I think this also for us, the message as the physicians, that we need to open the space for this.
Yes. And I think we as professionals, we need to be really humble.
Yeah.
I would never say to my patients that I understand how you're feeling, because I can't. I can hear the person and I can hear the experience and I can understand that sounds really hard. But like I wrote in that paper, I don't really know what it feels like to be 85. And when I will be 85, I won't be working hopefully anymore. So yeah, we'll always be younger than our patients. So I think we should listen to our patients as well and hear their perspective and what really matters to them. Because what matters to us, maybe it's not the things that are important for them. It might be, we might aim very high with something and they could be happy with smaller things, or vice versa. But if you don't ask, you don't know.
No. Yeah, I love this. So when we talk about these and knowing the patients, I think the ones who can help us a lot are the family. Yes. And I'm bringing now the family because I think this is one point that we wanted to emphasize. I mean, we're all experiencing these demographic changes in all countries. And sometimes I feel like everybody's getting in panic with all these changes. And one of the topics that we talk a lot in our congresses and meetings is the fact that we're having problems with nursing care, with nurses that may not be enough. But we also talk about the importance to recognize family as one of the most important supporting part that you have in the treatment of patients. And And I think it might be that we forgot what family it is in the last year due to the high mobility, but now we are realizing, perhaps we should actually go back a little bit to what is actually the nucleus of the society, the family. So how do you approach this in Finland? And what would you say? Explain maybe first what is in Finland the concept of family, because I'm coming originally from Venezuela and we have family. But now I learned when I moved to Europe, we have small family, big family, different concept of family. So maybe what is in Finland for you? What is understanding as the family, and how do you approach this to involve the family in the care?
That's a very good question. In Finland, I think Finland is quite an individual society, which brings some challenges to the aspect of family. And in some way, I feel that in Finland, people expect the society or the government to take care.
Okay.
The family members don't maybe feel that responsibility that I think in some other societies that are more family oriented. I think if you would ask a Finnish person what family means, they would say that it's the small family. I mean, the parents and the children. That would be a family. And I think it's very important that you bring this up, the how family, what an important role family has, especially in disorders like dementia and Alzheimer's disease. And I think families should be supported more. They should have more information. They should have physical help. Because taking care of someone 24/7, that's a very demanding job. And in the worst case scenario, if you don't take care of the caretaker, you're going to end up having 2 patients.
Yeah, that's true.
So even from the governmental side and from the economical side, it's cheaper to support the caregivers than to end up in this situation where both need help. So in Finland, there are lots of different programs in supporting the caregivers. I mean, you can be an official caregiver and you get economical support, and then you get, I can't really remember exactly, but it's a few days per month that you can get somebody else to come. So you can go and have your own time. Or if you're taking care of someone 24/7, that person can go into a rehabilitation place for 1 week. So then the caregiver can have a rest.
That's so important.
So these kind of things, they are really something that people talk about, but I think they should be emphasized even more. And these are things that I was talking about. This is for the official caregivers, but there's a lot of unofficial caregivers, and they are probably unofficial many times because they're afraid of being the official caregiver. They think that if they are the official, then it's going to be all their responsibility.
Oh, I see.
But that's not actually the case. But being official, you get more support. But in that way, I think it's also important to raise awareness in the general public that what does it mean to be a caregiver, that it's not just responsibilities, but it means that you are being recognized. I mean, even though you're not official, you're doing the same things. So it's a very important thing.
The official, everyone can be the official caregiver. I mean, the kids or I was just thinking now, niece or nephews. It's not
it's not dependent on their relationship you have. It's more
a good friend.
Yes, on how much time you use like how close you live, how close is the relationship. So yes, it can be a sibling, or it could be a cousin. Now this just brings to my mind another thing that I thought when you talk about family is that we also have to remember that there are a lot of people who don't have a family.
Yes.
There are a lot of older adults living alone. So
for these cases, what does Finland do? So how is the structure?
In Finland, we have home care, and home care means that you can have a nurse coming to your homes 3 to 4 times a day if needed. So in Finland, really, the policy in the last 10, 15 years has been to bring as much care to the person's own home as possible, to support living at home. So that means that you can have somebody, if you're living by yourself, you don't have a family, you can have someone from the city where you live at come in the morning, bring you medication, help you with the breakfast, then the same for lunch, and then the same for dinner. But of course, I mean, it sounds good, and I think it's excellent that we have this, but then 24 hours is a long time to be by yourself as well. So it really depends on your needs. For some people, this works really well.
But for other may not be enough.
Other, maybe not. Yeah.
But I think the main message is that as a society,
yes,
we need to solve this problem. No,
and we need to involve all the different parties. I mean, the official social and healthcare system, but also the third parties, lots of volunteers, also different associations doing really important work, and then the family members, neighbors. I mean, we're all
the community
itself.
The community.
Yeah.
It's very lovely. And when you mentioned, I'm just curious, can you tell about these possibilities the caregiver have to go to rehab or take 1 week off? Can you give a sense, based on your experience, how much % of the people do really use these possibilities? Because I guess it's not so high. I might be wrong, but
no, you're right. You're completely right. There's lots of caregivers who have such a sense of responsibility that even they are offered this chance, they don't take it. Which I think it's a really, of course, I can't understand how they feel because I'm not there, but from like my side of the table, from the doctor's point, I think it would be so necessary, because I really see this, that if there's one person taking care of another one, you really need to take care of yourself.
I always, when we listen to this topic to this problem in different scenarios, and I like always the example in the airplane when they tell to you, put your mask, and then you can help the other ones. When I say be vulnerable or recognize, I'm coming out to the limit.
Yes.
That's not a weakness.
No.
This is what I always tell everyone. This is a strength, because you're recognizing your limits and you're supporting, you're protecting yourself. And you're seeking for help.
That's so right.
And this is not weakness. That actually demands more strength than just carrying till you decompensate.
Yes.
And that is what we don't want.
And sometimes you are so tired that you can't see how much you need the rest. So then when you actually get the rest, then you realize how needed it was. So I think we need to be there to support the caregivers and tell them that, like you said, exactly. That's a good, I'm going to use this example now.
I always think on this, because it sounds, when you're in the airplane, you think, okay, why me first? But it's true.
Yeah,
no, you cannot help the others if you are in the wrong situation.
Very true.
Yeah.
Well said.
Very, very nice. So we're learning a lot here, not only about dementia, but also about Finland. I love it, to be honest, because it's very interesting to see. And I think each country can learn from each other as we learn here from each other. So may we go to the last topic that I think is important to emphasize, because sometimes we think someone is having dementia and then there is no need to do any other kind of intervention because that's worthless. And I think you did a very nice study that is called Finalex or Finalex.
Yes.
Finalex. And maybe you just explain a little bit the idea of this exercise on your patient and what did you see when doing this?
This was a big study done in Finland already some years ago. The main investigator in this study was my mentor, Kaisu Pitkälä, who's a well-known geriatrician, professor of general medicine in the University of Helsinki. And in the study, but there's so many things I want to tell you. but let me just first say that exactly, even though you have dementia, so much can be done. So we can get back
Take this message.
Yeah, that's the message number one.
Okay.
We can get back to that, but this study sort of like proves that as well. So in this study, there were about 200 Finnish people living at home, living with Alzheimer's. And they were divided into 3 different groups. And they had, one group was the control group that just got normal care. One group had physiotherapy sessions at home twice a week for 1 year. So 2 hours per week, like 1 hour at a time. And then the third group got physiotherapy, but it was a group physiotherapy. And it was also twice a week, 1 hour of the physiotherapy, but then they also ate lunch together and socialized at the gym. So we had these three different groups. And this study showed that doing this exercise intervention, there were less falls in the intervention groups, and it was cost effective. So even though we did this big intervention where we had a physiotherapy doing sessions twice a week, they used less health resources, both the caregiver and the patient. So the control group that didn't get this intervention, they used more healthcare resources during this year. There were lots of different findings from this study, but maybe I'll concentrate on the study where I was part of that looked at neuropsychiatric symptoms, which are the non-cognitive symptoms in Alzheimer's disease. So we saw that in people who had Alzheimer's and had neuropsychiatric symptoms, the more of the symptoms they had, the higher their fall risk was in the control group. So it went like linearly up. But the people who got the intervention, even though they had the same amount of neuropsychiatric symptoms, their fall risk didn't go up. It actually went a little bit down on the slope. So we could see that with the exercise intervention, we could really cut down on the fall risk that's associated with these non-cognitive symptoms. So that really brings us back to the fact that even though you already have diagnosed a dementia or Alzheimer's disease, there's always things that can be done. So for this reason, I think in the recent years, we've changed more the concept that we're talking about brain health. And brain health meaning that it's like a lifelong journey from when you're born, or maybe even before you're born, into the old age. And you can always do things to improve your brain health. You can improve your brain health in the middle age. You can, by preventing Alzheimer's disease, for example. But then even if you get Alzheimer's disease, you can still improve your brain health, meaning that your Alzheimer's symptoms won't be so severe. and that you live with better quality of life. So I'll bring it like back to the brain health concept.
And I would say that this kind of conversation actually goes into the idea of brain health, all synapses, having this conversation to get new impulses, to create new synapses, right, to come to new stuff and listen to the topic that really interests you. And I like that you point out this. So I encourage everyone to keep doing this kind
We're actually improving our brain health as we speak.
Yeah, exactly.
And the ones listening as well.
Yes. And for all of us, we need to say we haven't had this kind of conversation like this so far. No, yeah. We have talked about many different topics, but not in this way. And I'm really enjoying it a lot, Hannah.
Yeah, me too.
I really, really enjoying it because I see that we're bringing a lot of important information here, and perhaps we need to summarize now. Because those who are listening, we would like to talk like for hours. Maybe we'll come with another topic, no? Yes. I'm going to give you the opportunity to tell, based on all what we talk, what would you summarize? Talk about change, no? Observe your relative, see if there is a change. If someone was very communicative and going into apathy, don't let it stay. Just find out what's going on. Don't go to the wrong conclusions. I like the example you mentioned with the wife who was thinking he doesn't love me anymore. No, that doesn't need to be. Seek help. The first person will be the primary care physician, and be sure that they are not telling you this is all related to stress. That sometimes, unfortunately, we heard that. No. Please do a cognitive test, see where we are. And if it's needed, go to the next step, that will be go to the specialist. In Finland will be like the memory clinic, but not all the countries.
No, every country is different.
Exactly. Not all the countries have the memory clinic, but I can tell you that in every country you will find a specialist who is interested working on this topic.
Yes.
Okay. I think that's also important. Don't say, oh, in my country I don't have a memory clinic. Don't worry, you will find someone. And we also recognize that dementia is not only a cognitive issue. We also have other symptoms that accompany this, also motoric symptoms, and also psychiatric symptoms, and they need to be taken care of this, and also nutritional aspects that are quite important. Yes. We learn about family, how important it is, the family, how different the concept of family are. I think that's important to mention. But we also learn that as community, we need to work together. Okay, it's not. And we need to find a solution according to each community.
But I think that's our strength, doing things together.
Yes.
1 + 1 is not just 2, but when we bring our forces together, I feel confident that we can solve this equation.
Me too. I'm actually quite optimistic, and I would like the community, the newspaper, and everything to change the tone.
Yes.
Because we have a lot of strength in our societies and also in our younger people. But we need to talk together, to sit on the table all together and think, okay, so how can we manage this situation to go out of this? For the caregivers, take care of yourself.
Yes.
And seek help. When you need, say, stop. I can't anymore. I'm exhausted. I'm tired. I need air.
Need help before you are, seek help before you are exhausted.
That's a very good point. Exactly.
Yeah, because if you're exhausted already, then
it takes longer anyway to recover.
Yes.
And it's like to say, work.
Yes.
We work a lot. We do, Hannah. Sometimes, we
recognize these issues as well.
Yes, exactly. And yes, so, but that's a very good point that you mentioned, and the importance of keep exercising, keep doing preventive programs. No, for the finalist. So I think that for me will be all the very nice message we got here. If there is something that you would like to add or comment before we.
You did a very nice job. There was something that I was thinking while you were summarizing. And I thought, okay, I'll come up with 3 important messages, but I'll start with one that's very clear for me, which is it's never too late. I mean, for your brain health, it's never too late. There's always something that can be done. So I think that's one important message. And one important message for me is that dementia is not part of normal aging. So if there are symptoms, seek help, because there are things that can be done. We do have treatment. And then I think maybe the last message, important message that I would bring up is be true to what really matters to you. And if your doctor doesn't ask, bring it up yourself. These are conversations that we should have in healthcare. Maybe that's a geriatric message, but we often talk between geriatricians that it's not really what's the matter with the patient, but what really matters to the patient. So then I think I would like to finish with that, so that the people know that we do really care. It's about the whole person, not just the disease, but we're treating the whole person.
Thank you so much, Hanna. I couldn't say better. I'm sure that all listeners, I want to go to see Hanna in Finland. I really thank you so much that you were willing to have this conversation, that I think is going to be also very helpful. It opens doors for other conversations in other topics, and really give a lot of impulses, I'm sure not only for me, but I'm sure for all the listeners. So I think we can say now goodbye to all of the listeners, and we hope we can see you again. Thank you, Hanna.
Thanks for having me.
It's a pleasure.